Hi, I'm Lauren Henke, and welcome back to another NRG Oncology podcast. I'm joined today by my co-host, Stephen Chun. Today, our guest is Dr. Stephen Lai, who is a head and neck surgeon from MD Anderson Cancer Center.
For those of you who aren't familiar with my colleague, Dr. Lai, he's a prolific translational scientist, national principal investigator of NRG-HN006, and chair of the NRG-Oncology Surgical Oncology Committee. Dr. Lai, welcome. First off, what's it like a day in the life of Stephen Lai?
Well, thank you both for the opportunity to come and speak with you today on this podcast. I guess I would start with every day after kind of getting the kids ready in the morning. I like to take them to school every day that I'm not in the OR. And so that turns out to be at least 3 days a week. At work, I'm very fortunate. Every day is different, but we're always working towards the goal of improving care for our patients. I have a busy clinical and surgical practice taking care of patients with head and neck cancer. I run a number of clinical trials, including NRG-HN006, as well as a number of imaging studies aimed at looking at alterations in tumor metabolism to assess response to our therapies in the clinic, and also other imaging work to help understand normal tissue side effects resulting from radiation and systemic therapies. I'm also very fortunate because I have a basic science and translational laboratory where we're focused on identifying and developing novel therapies for head and neck cancers and also for anaplastic thyroid cancer. So every day is a little bit of different focus, but always an adventure.
Sounds like a great day in the life. Lots of variety. For those of our audience members who are less familiar with the structure of NRG oncology and its member makeup, could you tell us what a surgical oncologist really is? And also tell us about the role the Surgical Oncology Committee plays in our NRG organization.
So I think many of us take a multidisciplinary approach to cancer care with the three primary treatment modalities comprising surgery, radiation therapy, and systemic therapy or medical oncology. There are many other members of the team as well. In any clinical trial, experts from the various treatment approaches may participate. As surgeons, specifically, we may be asked to do staging or biopsies or tumor resection among other interventions for patient care. And so beyond the sort of technical aspects of, say, surgical procedures or our expertise in that realm, we are also interested in sort of the overall patient care. And as an oncologist, we're also working with our colleagues to kind of integrate the various treatment modalities together to optimize patient outcome. So I think that's what we mean generally when we talk about the surgical oncologist. Within NRG oncology, we're divided into a number of sort of committees and programs. There are disease site or disease specific scientific committees. There are non-disease specific committees that look at things like cancer prevention or developmental therapeutics or patient-centered outcomes. And then there's the scientific core. And the scientific core is a program of several kind of committees that are trying to help integrate sort of overall approaches to the various disease sites. So surgical oncology committee is one of those committees. The other committees include like medical oncology, pathology, radiation oncology, among others. But what we're trying to do in that scientific program group is we're trying to be a resource for the various disease sites. So surgical oncologists will come together from, say, head and neck and from, say, breast and from GYN. And what we try to understand are, do we have shared experiences as we're sort of trying to move clinical trials forward for the individual disease sites? And can we take those shared experiences and use or provide resources so that we can move clinical trial development along more quickly? For example, we may have operative reports or synoptic operative reports that would make sense, let's say, in sentinel node biopsy, to try to have a similar document in breast and melanoma and head and neck so that they can be shared because common information is sought in each of those particular disease sites. And so our work in Surgical Oncology Committee is to try to help provide those kinds of resources and to help our surgeons go back to those disease sites and facilitate moving trials forward.
And so oral cavity cancer is something obviously close to your heart, where treatments like surgery, radiation, and chemotherapy, essentially the multidisciplinary team, can have enormous impact on quality of life. Your protocol, NRG-HN006, is an important trial evaluating whether we can refine our surgical approach for early stage oral cavity cancer. Could we first talk about how early stage oral cavity cancers have been managed historically before we get into the details of your trial?
There are a lot of subsites in the head and neck, be it the oral cavity, the oral pharynx, the larynx, etc. And so management of the oral cavity, even as treatment sort of evolves and includes more aspects of radiation therapy and medical oncology, surgery remains the sort of primary modality of treatment for disease in that particular subsite. And so management of oral cavity cancer typically requires surgical resection of the primary tumor, maybe in the tongue, it may be in the floor of mouth, it may be on a portion of the hard palate or something like that. And once you remove the primary tumor, you have to then evaluate disease status in the neck. And despite our best clinical and diagnostic methodologies, approximately 20 to 30% of patients who have early stage tumors, and that's typically in T1, T2 tumor types, about 20 to 30% of those patients will actually have what we call occult metastases, or they'll have some deposit of disease that has then moved from the primary disease site into the lymph nodes or the cervical lymph nodes in the neck. And so we are then obligated, because that risk at 20 to 30% is high enough, that we have to be able to then manage or try to detect that disease there. Regional metastases, of course, are one of the great sort of prognostic risk factors for how a patient will do overall from oral cavity cancer. And so if we're not able to manage the neck, the patients are unfortunately likely to have a worse outcome. And so in head and neck cancer for many decades, the question was, do you do an elective neck dissection where you're removing sort of the nodal basin, typically on one side of the neck? The levels of the neck are anatomically defined, but you would remove, say, levels 1, 2, 3, and 4 of the lymphatic basin or neck nodes in that area? Or would you sort of observe the patient and wait until disease either occurred or did not occur, knowing that if you waited for disease to occur, that would happen in about 20 to 30% of patients. But if you went ahead and did an elective neck dissection, you would be removing uninvolved nodes in about 70 to 80% of patients. Well, a study came out of India in about 2015, and that was the first sort of level 1 evidence that really looked at that question of, do you do an elective neck dissection or do you do watchful waiting, as the term was used, and then do a therapeutic neck dissection in those patients? And it really became quite clear from that data that management of the neck was the best option for our patient. And so elective neck dissection has become sort of the gold standard for patients with early stage oral cavity cancer. But during that time, sentinel lymph node biopsy has also gained favor in a number of other disease types, including breast cancer and in melanoma. And the idea here is, if you can identify which lymph nodes are the primary or first echelon drainage for a particular disease site, then you can actually go and remove just that particular lymph node or that particular set of lymph nodes that's highest at risk for containing metastases. And the advantages there are that, say with an elective neck dissection, you remove 20 or 30 lymph nodes. Your pathologist then has to go and assess each and every one of those lymph nodes. For a sentinel lymph node biopsy, you may remove 2 to 3 lymph nodes. And so the pathologist can then focus a lot more of their attention and their resources to looking at just those sentinel lymph nodes. And so what that means from a practical standpoint is that typically in an elective neck dissection, those 20 or 30 lymph nodes will be bisected, and a single slice through that lymph node will be used to determine whether or not there's disease present or disease absent. So are the nodes positive or negative? With a sentinel lymph node biopsy, you can actually serially section through the entire node, typically at like 100 to 150 micron sort of thickness. Now you're actually sort of focusing your pathology resources on just the lymph nodes with the highest likelihood of harboring disease. And I think in that way, you then are able to not only identify sort of macro metastases, but also micro metastases, and even potentially isolated tumor cells for that particular patient. And so in a lot of ways, it sort of focuses your ability to identify potential metastases for those patients.
That is an incredibly helpful overview and a great setup for our next set of questions, which is tell us about the basic design of HN006 and its major goals.
HN006 it's a prospective randomized phase 2, phase 3 study. And we're looking at the two surgical options, namely sentinel lymph node biopsy versus elective neck dissection for the management of the neck and identification of potential regional metastases in patients with early stage oral cavity cancer. As with any good study, it's sort of built upon sort of the history in our particular field. And so once it was determined that active management of the neck was better than watchful waiting, then the issue that came to the fore was, well, then do we do an elective neck dissection or do we do sentinel lymph node biopsy? And sentinel lymph node biopsy, as I had mentioned, has really become standard of care for breast cancer, for melanoma. It has actually gained some more historical adoption in Europe and in Asia than here in the US for early stage oral cavity cancer. There have been a number of single site institution studies, some retrospective analyses. There are even some prospective studies, although perhaps underpowered to address this issue definitively. And that's really where an organization like NRG Oncology really gives us an opportunity to study this question at an appropriate scale.
So I can certainly see the potential benefits of the sentinel lymph node biopsy, less invasive surgery, more rigorous analysis of the sentinel lymph node. But I was wondering if you could share some of the possible risks of this approach. I know that sentinel lymph node biopsies are validated for a number of disease sites, but what might be some of the pitfalls we might see here with sentinel lymph node biopsies?
I think one thing that we're challenging and certainly the culture surgically now is we have gone from an era where sort of maximal extirpation or resection of more was thought to be always the best for our patients. You know, the greatest surgical traditions are en bloc resections. The dissection of lymph nodes from the neck started with the radical neck dissection, then became a modified radical neck dissection, and then has become sort of a more selective neck dissection, all in terms of trying to preserve normal structures in the neck that allow for better function for our patients. And so when we think about what we're doing with sentinel lymph node biopsy, we're actually now just trying to target, again, only those lymph nodes most likely to harbor disease. And we're able to do that because we can actually inject a tracer around the primary tumor, say in the oral cavity in this case, and follow the lymphatic drainage and use imaging technology like a SPECT CT to show where the lymph nodes are that are most likely to kind of contain disease or the first echelon or the first point of drainage into the neck. While that makes a lot of sort of anatomic sense and a lot of logical sense, we have to understand that for, say, other disease sites like breast cancer and melanoma, rigorous studies have been done to demonstrate that those types of pathology, right, the disease of melanoma is different than, say, squamous cell carcinoma, but that sentinel lymph node works clearly very well for those disease types.
Shifting gears just a little, Dr. Lai has also been a fierce advocate behind the scenes at NRG Oncology to make the language of protocols and consents more friendly to patients. What sort of terms concern you in protocols that might be off-putting to patients? And do you have any advice to new investigators writing trials about this?
I think medical oncologists and radiation oncologists have a very strong and rich history of conducting sort of prospective randomized trials. Surgeons, we are a little more comfortable with sort of reporting what our experience has been and why that experience might justify sort of the path moving forward. And so there's a little bit of a cultural shift when you're then talking about how do you approach a patient for a clinical trial. In a lot of ways, doing studies, say in transoral robotic surgery, all of those things are now new venues for established surgeons as well as our trainees and new faculty members when they are engaged in their cancer centers in trying to talk to patients about participating in clinical trials. And I think one of the first things you have to do is understand what the purpose is of a clinical trial, personally as a physician and then among your team members. The understanding that if we had the absolute correct answer, we would not be doing the trial. And so I think that's the first thing that we try to teach or try to talk to with our team members when we're trying to figure out how to approach our patients with our studies. When you talk about what we do in the sort of clinical trial realm, I think as physicians and clinical researchers, we use a lot of terms and phrases as well as a lot of abbreviations that are absolutely correct and technically precise. But I think when they're used in front of our patients and sometimes in our conversations with our patients, they may have some sort of embedded preconceived notions or even connotations that we're not always sensitive to. I think those things are important to kind of understand when we start to talk to our patients about clinical trials. I think we also always have to consider that ultimately there is a lot of psychological and emotional stress for our patients when they're contemplating cancer care and everything that's going to change in their lives. And then we're trying to then ask them to participate in a clinical trial or clinical study on top of that. I'll give you a couple of examples of words that we may use that could be sort of loaded with meaning in an already high stress environment. And I think one of them that I use quite often is this idea of randomization. And I think randomization from a statistical standpoint is absolutely correct. We're going to have someone other than us decide whether or not the patient is going to go on arm A or arm B. But when you use that word to someone who is not in clinical trials regularly or doesn't help design them or doesn't necessarily understand the statistics of it or why you would want to do a randomization, unfortunately, that term random suggests at times that you may be gambling, that there may be some arbitrary, and by arbitrary, I don't mean that unfortunately it can have a negative connotation, but that you're going to be kind of put in one or the other. And I don't think that a patient already facing a lot of uncertainty is necessarily comfortable with the idea of that term randomization, although it's from a clinical trial standpoint, a very sort of robust and very clear way to sort of put patients into the different portions of a trial. I think we talk to patients sometimes about equipoise, but I think what we need to do is tell them more clearly that if we knew option A or option B, if we knew one was better than the other, we'd be morally obligated to pick one or the other. But it's because we don't know the advantages, disadvantages so clearly between option A and B that's the reason we're having this study done. And while there may be some preconceived notions, there may be some idea as to whether one is better than the other, that we just don't have the quality or the level of evidence to sort of define that for certain. And that's why participating in a clinical trial may help us to answer that question. And then the third example that I like to give is we talk about sometimes that a patient goes off study. And we mean that they go off study in terms of what is the population or the cohort that we'll be able to do a statistical analysis on. But the idea of sort of going off study, I know can give patients some concern or some anxiety because they think, oh, well, if I go off the clinical trial, somehow my physician or my care team is going to be less concerned about how I do. And I think that's something that we just need to reassure our patients of, that they are participating in a clinical trial, but regardless of that participation, that their overall care is our number one priority, and that we're going to be taking care of them whether or not they are on study or off study. And I think we just need to be careful sometimes around the choice of words that we use to kind of inform our patients or sort of consent them to a particular study.
Well, again, Dr. Lai, I want to really thank you for taking the time and joining us today. These are just great insights for approaching patients for clinical trials in general.
I really appreciate the opportunity to discuss the work of the Surgical Oncology Committee, and I look forward to our continued work together. Thank you very much.
The NRG Oncology Group is supported by grant funding from the National Cancer Institute of the National Institutes of Health, and the content of this podcast does not necessarily represent the official views of the National Institutes of Health. Thanks, everyone, for tuning in, and happy trials.